very much, and happy birthday to Skip. So I normally, coming from academia, plan for about an hour, which I know we're not going to do today. So let's make this conversational. So if you have questions along the way, please don't hesitate to interrupt me. And if maybe I should distribute the bell. If you want me to skip ahead, just hit the bell and let me know. But this is for you, so let me know if there's topics you want to cover. The broad purpose here is to discuss the healthy brain. So I'll start with a little bit of background about why you should maybe listen to me, and then I'll get into some background about the brain, what we know, we don't know, what I as a neurosurgeon do with the brain, and then I'll get into some of the habits that have been, most of you already know, especially Skip, but in terms of what would be beneficial to, what has been shown to be beneficial towards maintaining good brain health. So the answer is not another pill, the answer is spinach. And that's a quote from comedian Bill Maher, but the point is probably well received by all of you who understand this. But nonetheless, we'll go into greater depth. And it's not to say people haven't tried. This is it's intent, you're not supposed to be able to read this. But the idea here is this is a list of studies. There are 106 animal trials with the National Institute of Aging that have looked at what can improve longevity in mice. And the thing I want to take away from this is not what's on that list, especially since it's very difficult to transition those results into human lifespan, but also to talk a little bit about the difference between lifespan and health span, right? It's one thing, and it's easy to quantify the number of years a person is alive, less easy to quantify what health span is. And by that I mean the quality of life, so the good years, and holding on to that as long as we can. Now, a little bit of background about me before I go on. You know I'm a neurosurgeon, but I want to give maybe a little bit of my story, how I ended up here and what neurosurgery is. This is from the Metropolitan Museum. It's about when Theseus slayed the Minotaur. And for me, a lot of my road to neurosurgery began in college when I was studying philosophy and really interested in what makes us who we are. And this is a classic teaching, I don't know if it's a parable, but the idea is that the ship of Theseus, and a little background there, Theseus was famous for slaying the Minotaur, and he went from Athens and fought the Minotaur, came back. This is him leaving Ariadne on Naxos. He kind of abandoned her there after she helped him slay the Minotaur. But the point is, he came back to Athens a hero, and each year they would take his ship and they would celebrate with a pilgrimage to Delos. The thing is that the ship over time needed repairs, and so each year they would have to replace this, maybe the mast or some of the planks, and the ship over time was replaced with entirely new parts. And so it leads to the question, and this is maybe what philosophers do, but the question of who are we? What is a thing when you are changing all of its parts, right? Did this remain the ship of Theseus? There's continuity, there is the same form, but entirely different parts. And I think it applies because we as people do the same thing, right? The ship of Theseus was kind of a thought experiment, but in a person, our cells are completely replaced, right? We have about 30 trillion human cells, and about 330 billion of them are replaced each day. So every 100 days, you go through that many cells. Now, the truth is many of those cells are not replaced. The heart, the brain, has a fair amount of continuity, even though they are in flux. But the point is, what is it that makes this baby, this adolescent, this adult, and this person later in his or her life? And that sort of what led my interest into the brain as the foundation of that, and the part that maybe is consistent throughout. What is it a person's memories, their relationships, that make them who they are? So, to that point, what is it to be human? I don't know if you can all see this. This is the bane of many of us, right? You're trying to check out. And CAPTCHA stands for the Completely Automated Public Turing Test to tell computers and humans apart. I probably don't have to tell anyone in this audience who Alan Turing was, but the point is that clicking on the boxes that are traffic lights is hard enough for us sometimes. I don't know about you, I sometimes have to go through a few. But the point is that it's comical. You look at what ChatGPT, if you just Google on a YouTube video trying to do this, and it's not there. It may be there at some point, but that's a part of what it is to be human, is to be able to complete tasks like this. What is this? Can everyone see? Anyone just shout it out? Sorry?
Squirrel eating a nut.
Right, but it's not. It is a drawing of the squirrel. and the point, right, Asher? I didn't show a pipe, but I'll show that later. But the point is that you're able to make that leap, right? And never mind the semantics, but this is just not even drawing, right? This is light projected onto a screen, shaded grays on a white background, and yet you're able to make that leap. How about this?
It's a photograph.
Right, exactly. Another thing is the capacity.
By James Hart.
Right, by James Hart, perfect. So that making those leaps is something actually that some AIs, and this is one of the big ones, right? OpenAI's project with ChatGPT, all the big tech companies are coming out with them, with AI models, and there's a lot of controversy about what this is going to mean. And I'm not here to tell you because I do not know. But what I can tell you is, as a neurosurgeon, my focus is on the nervous system. And that is what makes us human, among other things. My brother's a cardiologist, so I have to give it to you. But the point is that the brain, the spine, and the peripheral nerves make up the nervous system. As neurosurgeons, we work on those parts of the body. And it's generally structural pathology with them, to distinguish from neurology or other neurosciences that are often dealing with non-structural causes of trouble. So this is an explanation, a little bit of depth into kind of what the operating room is schematic for, and then how we access the brain. We use a number of tools, right? So you have the neurosurgeon here, and the center is the patient. We use navigation systems. This works a little bit like a GPS, a global positioning system. We use microscopy to bring light, magnification, depth perception deep into the brain, and then we have special retractor systems that allow us to access. And our goal, and this is really as one of my mentors used to say, brain good, tumor bad. And in a way, it does boil down to that. We're trying to access the nervous system with as much accuracy and safety as possible, but to get the job done, and to get the job done. This is my office, but despite, and this is a little bit of an amped up view, but again, you've got a lot of technology that helps us do a better job with this. But that's once you're in the operating room. And I'll show you some about what we do in the operating room and some videos. But the goal is to keep you out of the operating room, right? To keep you guys from ever needing to see me. Okay. So a little bit of background into what the brain is and some neuroanatomy. And if this gets too boring, you just let me know and we can fast forward. But these are you probably have heard it, the frontal lobe, prefrontal cortex. These are descriptive terms that are really helpful for us, right? If I hear from a resident who's calling up with the consult, they can tell me, I can get information about where the problem is and what's going on. But you have the frontal lobe, the motor and somatosensory cortices, the parietal lobe, occipital lobe, temporal lobe, cerebellum. The point is that we use that, we're trying to understand something, but this wasn't set up for us to understand it. It was set up for us to be able to understand, perhaps. But the point is that our models have been evolving, but it's still useful to understand this, that motor cortex and sensory cortex tend to be localized. What that means is an injury in those areas would lead you to have weakness or numbness. But obviously it's much more complicated than that. We go back to the picture of the squirrel, you see that. It comes in the image, the light bounces off of that, or is emitted from this screen. or actually emitted from this and bouncing. Anyway, the point is that it's going into your brain to the occipital lobe, and then you have to process it, right? And that is a diffuse process that goes through networks, and I'll get into that a little bit. This is now looking deep within the brain, the thalamus, the hippocampus, the hypothalamus. These are some of the structures that are very similar between all of us and our dogs and our cats and hamsters and so on. These are really fundamental structures. The hypothalamus involved with hunger and satiety and sleep and wake, when you feel tired or not, as well as a number of hormones. The thalamus takes all the sensory information that comes in and processes that. The hippocampus is critical in forming new memories. A lot of what we've learned comes from the pre-MRI era, before a lot of the technology that has solidified our understanding, but people would have injuries, right? They'd have bilateral hippocampal injuries. Anyone here see that movie Memento from about 25 years ago? Where, right, there are people like that who cannot form new memories. And that was in this movie, the point was he couldn't form new memories, and so he had to come up with ways of routine to make it work for him. So the hippocampi are important. There's also, I should mention, a great deal of redundancy. So people with unilateral injuries can do often very well. There are some things that are not so bilateral, but many things are. So now going down into the microscopic, this is a schematic of a neuron. So you have dendrites, the cell body where the nucleus is, and then it projects an axon. And an axon is like, funny, you can't get a phone with a cord so easily anymore, but if you look at a phone with a cord, it's got the insulation, and that's what this myelin sheath does. That creates fidelity with the signal. And if you've ever known anyone with multiple sclerosis, it's that gets broken down and leads to poor transmission of that signal. And our neurons, there is some development and there is some turnover, but for the most part, our neuron number is pretty fixed beyond childhood. But obviously, I mean, you guys are here and this is a vibrant community making an impact in the community because you're able to form new memories, you're able to learn new things. And that comes largely from the relationships between neurons and neurons between the different neurons, and that happens with dendrite formation and forming new connections with the existing hardware, if you will. And this is what's going on at that junction between one nerve and another, or between a nerve and a muscle, is you've got little vesicles, little spheres filled with proteins called, or not just proteins, with signaling molecules called neurotransmitters, right? So serotonin, dopamine, these are some of them. And it's an incredibly complex process, but we do understand on the micro level that an impulse through a neuron causes release of neurotransmitters into the junction between that neuron and the synapses, the cell bodies of another, and there are receptors that will read that. There's also a reuptake mechanism. So we've heard of SSRIs, or selective serotonin reuptake inhibitors. They stop that reuptake. So there's a lot of ways that the signaling process can be modulated, right? It can be released more, reabsorb more or less, and you can have different volumes of receptors. So another busy slide, but the point here is that we have learned a lot about where things localize in the brain. And speech is a really interesting one where it kind of takes everything, in a way this is a big part of what it is to be human. It takes the information that you have with the world, right? You're hearing my voice, am I a threat, am I a friend? What am I saying? Is it interesting or not? Attention, all of that has to be processed through all these networks, but a substantial portion of it is localized for most people, about 99.9% of right-handed people and about 90 to 95% of left-handed people, around the left frontotemporal lobe. Okay, and so that's relevant as a neurosurgeon because if I have pathology there, I have to know that, right? I can't just go into that area because again, brain is good and tumor is bad. And I can't, if I've got some, well, we'll get into that. So, but it's also to point out, and you guys can't see this well, but this is related to the parietal lobe. You have picture naming, text reading, sentence completion, text writing. In the frontal lobe, similar things, but auditory naming, temporal lobe, you have a little bit more of that receptive. And so taking that information in, other languages, so those of you who learned a language, your first language when you were very young, a second language also when young versus later in life, can be localized in different places. So MRI, and this is just, got to make these slides less busy, but the point is this is just showing you some pictures of MRIs, and I'm going to explain. So an MRI is short for magnetic resonance imaging, and it is an incredible way of looking inside the brain, both structurally and functionally. Structurally, what it does is it allows us to take this three-dimensional object, put it on a two-dimensional screen, a little bit the way you would with like a loaf of bread, right? Let's say you wanted to see what was going on, you've got your loaf, you slice it up, you can look at one slice at a time, and that's what each of these is. It's a slice through the brain in different directions. And I just wanted to give that background because that's what this is. This is one of our patients who's got a tumor in the left temporal lobe. So this is a cross-section through the brain, right? And so you can see the eyes, and it's like we're looking at her. So the same way that my left ear is on your right, this person's, him actually, left temporal lobe is on our right. So this is, you can sort of see, I don't know if it projects well, but in the left temporal lobe, there's a signal change, and that's a low-grade tumor. And the thing is, it's very infiltrative. And so the goal here is to get out. This patient just presented with a seizure, no language issues, but we wanted to get this tumor out, get as much out as possible without causing any new problems. So this is how we do it. This is the operating room, and this is the patient lying down like this, facing away from us. This is placing a head frame, and this is kind of what it looks like before we start the surgery. And once we drape, we prep everything, make it sterile, or very clean, and then we place a drape. So on one side of the drape, you've got, this is the patient's head, the surgeon, and on the other side of the drape is the rest of the patient, and access for the anesthesiologist, and we have a team of neuropsychologists who can test things. So the arm is open, so we can test motor function, and then the patient is going to be awakened so that we can test speech. So this is that same patient. You've got the temporal lobe here. The patient's facing that way. So frontal lobe here. The patient's ear would be kind of here, the eye looking that way. And so this is the temporal lobe, and this is the parietal and frontal lobe. So these are little like silastic markers. They're just little pieces of special sterile plastic with letters on it. And what we do is we map out with an ultrasound the tumor, right? And so these are our boundaries of the tumor. Then this is the way we're testing. So this patient is now awake, looking at this computer screen and saying, this is a chair, this is a squirrel, this is a pike, right? And so we're able to test visual appreciation for what's going on, and then taking that information and turning it into a expressed sentence, okay? Meanwhile, they can move the arm. And so we're able to test all these things with the patient immobile lying on a bed. And it allows us, while they're doing that, the surgeon's on the other side, and we're mapping things out. So this is a bipolar stimulator, which means it sends a very small signal of electricity between the two probes. And while the patient is saying, this is if we tap on that spot of the brain that's critical to that speech expression, or certain things can hesitate, we can mark out, okay, that's where that's localized in the brain. So this is a wake mapping to again, using our understanding of the brain. Yeah?
So we've been reading in the press about people putting chips in the brain. Wondered whether you'd done any of that or had any opinion on that.
Yeah, so my focus has been on dealing with pathology, but yes, so there are, for certain kinds of epilepsy is a good example. There are stimulators we can place for people who aren't responsive to medications, don't have a single locus. It's a little bit like a pacemaker. They call it neuropace. You can put a chip on that will detect a seizure and can kind of jumpstart it in an effort to stop it. There's also deep brain stimulators for people, you may know people with Parkinson's disease. That's deep within the basal ganglia. The thing about those is most of them are about, for paralyzed patients, it's still pretty rudimentary. You know, there are some who are better at marketing what's going on, but that's going to be, I think, an incredible use of AI, and the future is really bright with that. But right now, a lot of the chips and implants do things similar to what lesions would do, and to some extent, people can develop some function. So spinal cord injuries, people are doing similar things. They're just placing chips on the temporalis muscle, which a lot of people who have spinal cord injuries still have use of, and they're able to just use contraction of the muscles in the temple to transmit signals to limbs to do basic functions.
Wow.
But yeah, that's something that I think the last 20 years has seen slow progress, and I'm hoping we're going to see increase in the slope of that curve of improvement. So once we've mapped it out, then we can go towards resecting the tumor, and that's what this shows. Other things we can do within the brain to keep an eye on what's going on. This is a different patient who has a higher grade tumor. You can kind of make out this is the tumor, and this over here is more normal brain, but the junction isn't great. And so what we can do is we actually inject fluorescent dye, and we use a special filter in the microscope. That's what you see here. And as that dye is injected, it lights up, and you can see better some of that tumor at the margins. And that helps, again, maximize our resection while minimizing the risks to the patient. This is a schematic using something even less invasive. It's a laser ablation technique where we place this frame on the patient, and this is like an old slide rule, actually. My dad was a pretty nerdy engineer. He gave me a slide rule tie clip. I should have worn it today. But anyway, the point is we're able to plan that trajectory, again, using what we know about neuroanatomy to make it safe, and we're able to make just a 1.3 millimeter diameter hole in the skull, and then we place this laser probe into we bolt it down onto this is actually placing the bolt, and you'll see we take that frame off, we place the laser probe through that, and we're able to target the tumor with virtually no damage, very small hole to the surrounding structures. And again, we know about neuroanatomy to really minimize the risk here. So once the probe is in place, we transfer that patient to the MRI suite. You can see the laser cable coming this way, and you've got the surgeon and the MRI technologist. So we're able, under continuous views of the MRI, this looks more like me than this, but still, the point is we're taking pictures while we heat up and ablate that tumor.
Yeah. Wow.
So we take advantage of the really smart people to figure out this technology to be able to bring to patients and make their lives better. So this is hopefully a little bit of background about neurosurgery and what we're doing and about the brain. I'm going to transition now, and again, interrupt me if there's questions anytime. I'll transition into a little bit more about some of the things we can all do to maintain brain health. Okay? Any question? Go ahead.
Yeah, I just wanted I, along with millions of other people, actually struggle with tinnitus. And so my brain is thinking it hears loud sounds, which are really not occurring at all. It's as though I'm actually sort of in a shower most of the time, hearing this background noise. And I just wondered if there's any sort of help in sight to help people not have that noise in the background.
So, I don't know if you were a plant by one of my enemies, but that's one of the things that we're really bad at. And we sometimes, there are different causes of tinnitus, so it may be worth having an MRI at some point, because sometimes there can be small benign tumors that cause pressure on the nerve. But it's one of those things that's really tenacious. It's really, my dad tells me about this. He's got tinnitus too, and it's a tough one to solve. There's different causes, so the first thing is to figure out why you're having it. I assume you probably have seen an audiologist or an otologist. It depends, right? Is there a peripheral stimulation, right? Like we all probably have been to a loud concert or heard a loud bang and you have a little ringing. That's thought to be from the, okay, so we have to take a half step. What is it to hear, right?
How about artillery shells?
Right, artillery shells.
2 years.
Yeah, and did your ears ring from time to time after?
Constantly.
Yeah, so what's going on there is when you have the vibration of air from artillery or music or whatever loud things, right? It's causing vibration of the tympanic membrane, the eardrum. And that's connected to these very small bones that just kind of amplify that vibration into the a window, essentially the cochlea, right? And that's, if you look at it's like a nautilus shell-shaped object within the brain, or structure within the brain, and it's curled, and it's got different diameters, and there are these little projections, these cilia, that depending on the resonance, right, depending on the frequency of the sound, is going to cause the vibration of specific ones of those, right? So depending on the diameter and the specific notes, right, the specific frequency of the sound, and that's going to the projection, the deflection of those cilia is going to cause the nerve signal in the cochlear nerve that goes to the brainstem, and then that gets processed there, right? That's very important towards distinguishing. You could probably, before you even process what you're hearing, you're processing where it is, right? That can be helpful from a very fundamental survival perspective. But then it goes up to the brain, and you have to figure out, was that artillery? Where did it come from? Who's firing it? Do I need to tell my teammates or my fellow is it friendly fire or enemy fire, and so on. So, but to the point of tinnitus, it can be, the thought is when you have it from a loud noise, it's because those cilia are being damaged, and so the signals are getting sent. But it can also be from things within the brainstem, and there are some treatments that are available, but perhaps we can talk later about what we could do there. But it is a tough one.
What do you say?
To do a whole other talk on comedy, and anyway, that's it. So for brain health, the basics to start, right? This is, I think, actually meant to be an ad, but the point is smoking, drinking. We were hoping for a while that there was some evidence that alcohol in moderation would be good for us, but it doesn't seem to be the case. So if you can cut out these basics, and I'm not telling you can't have a cigar on the golf course with for a good cause, but the point is that these are bad, and so that's a good place to start before we get into anything else. Exercise, right? So this is really important. This is one of the few things that's been studied extensively and has shown improvements in cognitive function, memory, really across the board. So, people knew this a long time ago. There's George Bush Sr. and Arnold back in the 80s really kind of pushed the initiative of exercise and how important that is. It's important to build oxygen capacity, right? So doing some kind of aerobic exercise. Muscle mass, right? We're all losing about 10% of our muscle mass each decade after our 20s. So doing what we can to hold on to that is important. And then flexibility, balance, right? So that when we do take a stumble, it doesn't turn into a fall, and if it does, we're going to distribute those forces more widely in our bodies and be less likely to hurt ourselves. It's also, this is looking at different, so executive, controlled spatial speed, these are different kinds of tasks between people who've been exercising in red versus controls in blue, and this is the effect size. It's pretty substantial. And this is a quote at the top from Nietzsche: all truly great thoughts are conceived while walking. And the truth is, we're talking about exercise that gets you to about, we call it zone 2, we can talk about that more later maybe, but the point is just some moderate exercises. And in this next slide, I'll talk about exercise recommendations for different ages. So preschool age children and adolescents should be exercising constantly. I'm here talking to you. I need to do a better job getting my kids off their butts and outside. But that's really important. But then as we get older, it's very important. And the recommendation is at least 2 days a week of muscle strengthening exercises, and then you should be aiming for about 150 minutes a week of moderate intensity activity. So that could just be intense walking. If you have one of these watches or a heart rate monitor, it's getting your heart rate up, maybe into the low hundreds. It's not like you don't have to go out and run a marathon. In fact, we can talk later about why that might not be good, but it's important to maintaining health. 36,000 falls, 36,000 deaths. This is going back a few years, but falls among adults 65 and older are the leading cause of injury-related death for people. So,
is that an annual number or?
Yes.
Oh,
Yeah, and there's a great book called Factfulness I recommend. Be suspicious of any numbers without a denominator, but that's, like 360 million now, right? But the point is that simple things you can do, make sure that the rugs, the edges are tacked down, keep a light on in the bathroom. As a neurosurgeon, I have a bias in terms of what I'm seeing, but too many people come in because they tripped at home and fell, and now it's not a great way to go. Other things too, when you're getting up at night to go to the bathroom, or even at any time, sit at the edge of the bed for 10 to 30 seconds or maybe more to let it's kind of amazing that our blood vessels and our heart can maintain about the same amount of blood flow to our brains, whether we're standing up, running around, or lying down. That gets harder as we get older. Peripheral vascular resistance takes a little bit more time to adjust. So sit at the edge of the bed, let things adjust, and then get up while you still have the bed behind you. Make sure you're okay, because syncopal episodes where people pass out are a common problem. Physical health and mental health go hand in hand, and this is something that's really important. There's a lot of data to support that chronic stress and depression and anxiety can really affect your mental health. And to that point, it's a complicated one. I would say, tened nocere, know yourself. And we're all different personalities. There's some really good books I could refer you to on that, about ways you can, in knowing yourself, find things that make you happy. I don't need to tell this group, actually. The fact that you are all spending your time trying to learn new things, focused on giving to your communities, is a huge part of that. And that's really important towards maintaining good mental health and brain health. This is a study, or the data from a study that compared mindfulness-based stress reduction plan that was part of, this came out of John Kabat-Zinn. He was a professor at University of Massachusetts, and this is going back like 40 years. He actually studied this very intense meditation program, and it is very time intensive, but that's compared in blue to the orange line, which is escitalopram, which is an SSRI given largely for anxiety. And this is the anxiety scores, and you can see they're almost exactly the same. Going through, now the program was 45 minutes to 2 hours a day. It's a lot versus the pill, right? But it's a good example of how mental health is dependent on mindfulness and meditation. This one, sleep. So I love this picture, because anyone guess where I found this picture?
Mattress commercial?
Right, you'd think so, right? Or some kind of fluffy. So this comes from the Air Force Materiel Command out of Wright-Patterson Air Force Base in Ohio, right? They understand that to avoid errors, to maintain a vigilant air defense, you need people who are well rested, and that is really critical. Sleep is modulated in a very fundamental part of the brainstem, right? So this is something every animal sleeps. Right? I don't know about the trees, but every animal sleeps, and it's really important towards, well, do we understand exactly why or how? No, but we do know that happens, and there are some rhythms that we do understand, right? So this is looking at levels of melatonin and how those change throughout the course of the day, and the white line is body temperature. So there are clearly rhythms in our bodies. So coming up with good routines is really important for sleep health. And getting enough sleep is critical. This is the average amount of sleep we need over the course of our lives. When we're babies, it's through the roof. For children, it comes down a little bit, and as we get older, it's probably a little bit lower. But a lot of times people think we don't need as much sleep when we get older, mostly just because of other things, right? Whether it's our prostates or our whatever it may be, or I'm not going to get into all that, but there are a lot of reasons we get up at night that aren't necessarily because we don't need more sleep. So some tips towards getting enough sleep: set a schedule. And this is, again, very busy, but if I can send it to anyone if you want it, but go to bed and wake up at about the same time each day. That can be helpful. Exercising is really important, but do it earlier in the day, right? You don't want to be exercising within a few hours of bed. Actually, the last time I was driving by here, I played hockey at Twin Rinks, and being old, they would send us to the 10 o'clock. I have games starting at 10:30 p.m. I'd get home and I couldn't fall asleep for a while, so that's not a good thing. Avoid caffeine and nicotine later in the day, and alcoholic drinks, although a lot of people will enjoy a cocktail to go to sleep. It's not as good sleep. It's a little like anesthesia. You're not getting the brain activity on an electroencephalogram that you need to be getting. Try to relax before bed. I can go into when we're running out of time, so I don't want to belabor all this, but we can talk more. Nutrition. I leave this last not because it's least important. In some ways, it might be the most important. It's just so brutally difficult to study. This is looking at the difference with people on the Mediterranean diet, right? This is a Hippocrates quote. Our food should be our medicine, our medicine should be our food. I can refer you to some books on this, or we can talk all day about nutrition. But the point is that diets that emphasize plant-based foods, fish, olive oil, whole foods, limiting saturated fats and sugars are probably more important than just having calorie-restricted diets, okay? And I'm sorry I can't go more into that, but this is just, again, looking at that, and there wasn't significant differences. In terms of how we think of aging, it's a process, right? We all know that, but the idea is that there's a certain amount of compensation we can do. There's another book I recommend, From Strength to Strength, from Arthur Brooks. It's really good talking about how we go from the athletic, quick mind to the wise mind, right? As we age, we can't be quite as quick on our feet, but we can compensate and we know how to work instead of just able to work all day and all night. And the idea is that there's sort of this threshold that we cross at some point where we start to decompensate. We can no longer compensate for getting things with routine and habits. And that the idea here is that if we can take steps, right? Early life exposure to risk factors, other problems, smoking, all those things can make it so that we accelerate brain aging versus taking good habits early on and trying to avoid that altogether. And this is another graph that sort of shows it too, is that we have this sort of resilience, and that when we have adverse events, it takes away from that resilience and moves our whole curve over to the left, where we're going to start to age in a bad way early on. Most of you don't have to worry about that. You're clearly doing very well. Again, I was told we have a hard stop at 1:30, so I'll skip this and go to the summary, which is get rid of your destructive habits, smoking, alcohol, work on fall prevention. A routine with exercise in it is important. Mental health, social engagement, I mean, you guys preaching to the choir on that. Getting good sleep, eating a good balanced diet, avoiding processed foods. And then the basic things, health maintenance. There is a role for exogenous compounds, by which I mean, medicines and so on. And so making sure that your blood pressure, blood sugar, cholesterol are all well controlled. So.
Wow, thank you. Thank you, Mark. Outstanding, and I love hearing that, and I feel inspired. I'm going to live another 100 years, right? There you go.
Happy birthday.
Thank you.
Thank you.
Thank you.
And we're out of time, but if any of you has questions you want to ask me after, you can catch me. I'll be here for a little bit.
Thank you.